Thank you very much, and I'd like to reiterate some of the comments made this morning, congratulate Ahmed and Ziad on a fantastic conference, and very honoured and grateful to be amongst you. So I suppose most of us like to think we spend our days like this in a state of constant enlightenment, not only in life in general, but also in relation to our practice and our patients, and perhaps even to coronary artery assessment. I suppose it's not something that comes naturally to a lot of us, because as congenital or pediatric cardiologists, we don't spend our lives looking at the coronaries. So perhaps instead of looking like this, most of the time it's a little bit more like this, whereby we're staring down at something that we don't really fully understand, and we don't really know the sort of the start or the end of where the issues may be with it. And I hope I can shed some enlightenment on it, although I'm not so sure. So I've been given the task to talk to you about how should we do it, and I suppose it kind of comes with a little bit of a caveat of it kind of depends. And I'll constantly come back to three different things in relation to this talk. One is the substrate that we deal with, and I think that is important because there are different types of substrate. We have the RV to PA conduits that can be heavily calcified. We have the bioprosthetic valves, which some people feel a little bit more protected by, and then obviously the native outflow tracts that we've seen this morning with Ahmed so skillfully replacing valves with. And as well as the substrate, then we have, and obviously whether stenosis or regurgitation is a predominant factor in each of those variables is important for us as well. As well as the substrate, then we have the technique. What technique should we be using? What type of balloon should we be using? And whether we should be using serial inflation techniques or not. Should we be using aortic root angiography or selective coronary angiography? And each have potential risks, well, I suppose benefits and downsides. And then is there any new evolving technology that might help us to evaluate whether the coronaries are at risk or not? And then finally, how do we interpret the data? Once we've got it, we need to be able to make a call on it. When there's clear compression of the coronary arteries, it's an easy call. You know, I think probably most of us would hopefully consider bailing out at that stage. What about if there's compression of one of the smaller branches, or suspected compression of one of the smaller branches? What should we consider doing? And then I suppose the final question is, what about proximity? Because this is the problem that we're left with most of the time is, well, it looks kind of close. How close is it? How close is too close? And I think that is a challenge for us all to determine. So before we kind of go into it in a little bit more detail, I just wanted to point out that this, I suppose, a somewhat new phenomenon, because we've been only doing transcatheter pulmonary valve replacements really for the last decade, but there has been some data out there. Lynn Peng, when she was in Boston, evaluated pre-stenting of the RVOT over a 15-year experience and showed that coronary artery compression occurred in 3 to 4% of patients in her cohort. So we did kind of know about it, that it was a potential risk. And since that time, as pulmonary valve implantation has evolved, we can see there are a number of other publications and reports of compression of the coronary artery. In fact, from some of the groups in this room, from Mario's group in Italy and Milan, and also from Mark's group, suggesting that coronary compression can be an issue not only with RVOT stenting, but potentially with branch pulmonary artery stenting as well. And then I suppose to come back just to the final one on the bottom of the screen there, is that the concept of coronary artery compression from pulmonary arteries has been known about for even prior to the point of which we've been doing implantation of stents. It's been reported in patients with severe pulmonary hypertension, whereby we get these big dilated pulmonary arteries that are pressure loaded and may compress the coronary arteries. So, you know, this is a concept that has been around for a little while. And although there have been some reports, it's really only in the last couple of years when the Melody cohort or group decided to look at it a little bit more formally and publish it in Circulation Cardiovascular Interventions, where they evaluated 404 patients in relation to predominantly Melody valve implantation to look at this in a little bit more of a scientific way. And sorry for the busyness of the next slide, but the demographic of the population I think are important. We can see that most of the population of the 404 that were implanted had tetralogy follow, and we can see that most of them had homographs in place. There was coronary artery compression described in 21, which is just under 5% of the cohort. And in fact, one of the things I'll talk about is the importance of pre-assessment. Actually, 4 of the patients had pre-existing coronary artery abnormalities before they ever balloon assessed the RVOT. So it's a really important thing to assess the coronaries with initial injection or with the CT scan that's been discussed this morning, before we kind of get to the point whereby we make a decision on whether the coronaries are actually abnormal with the balloon inflated in the RVOT. And then when we look at the actual cohort of those who had compression, 19 of them actually didn't have a valve implanted. So with 2 patients, even though there was some suspicion of coronary artery compression, they actually managed or decided to proceed and put a valve in a little bit lower down than where the coronary artery was thought to be impeded upon. And when we look at the distribution, so 19, as I said, just 5%. The other interesting thing about this is that coronary compression testing was only performed in 41% of patients, which is, was very surprising to me. I think, obviously, I hope most of us would now consider that this is a routine thing, but certainly in the cohort that was looked here, it wasn't a routine approach. When we look at the actual sites of compression, 43% were the left anterior descending coronary artery, 23% the left main. Sometimes we don't think the right coronary artery can be compressed. It can be in about 1 in 9, 1 in 8 of the cases that we see, and then other smaller branches in about 1 in 5. So when we look at our pre-assessment, again, this is the important point that the group make from this paper, is that this is a 32-year-old man who had transposition of the great arteries with a VSD, who'd undergone a Rastelli procedure. And you can see that there's clear compression of the right coronary here prior to actually any balloon assessment of the right ventricular outflow tract. And you can see then on the right-hand side of the screen that there's retrograde filling of the right coronary from the left side. So really important to pre-assess before we do any dynamic testing. And I think it's the same with anything we do. Before we go into battle, you really should know your enemy. And I think previously we've been limited by, what we have had access to or what we've known, whereas now we're really limited by our ability to be able to read the literature because there's so much of it out there. And again, I think the paper that I am discussing at the moment is a vital part of me going through this talk, and hopefully you interpreting and acknowledging the importance of certain substrates in relation to high risk. And again, Google and PubMed are a very important part of our work flow today. So again, I think this is a sort of slightly busy slide, but the question is important. Who is at increased risk? Well, again, when we look at those with abnormal coronaries, 71% of those with abnormal coronary and artery had coronary artery compression, and the majority of those were the LAD. And I think, again, a lot of those were where the LAD was arising anteriorly from the rightward or the anterior-facing sinus. And the other thing that's important from this graph to outline is that those with transposition of the great arteries, 33% of the whole cohort had compression, coronary artery compression in the setting of transposition of the great arteries. And obviously, with 404 patients and only 37 of them having transposition, it's a minute or a small overall proportion of the whole cohort, but it makes up 1/3 of those who actually have coronary artery compression. So again, I suppose what I wanted to emphasize is the importance of knowing the substrates that are at high risk. I think when you come down to the bottom of the screen here and you look at the conduit type as well, majority of patients obviously had homographs, and majority of patients with coronary artery compression had homographs, but nobody's immune to this, particularly those who have bioprosthetic valves in place, and also the native RVOT as well, so something to be mindful of. So again, this is the concept of the abnormal coronary arteries that we've discussed. 71% of those with coronary artery compression had abnormal coronaries versus 14% of the normal population, highly significant. The majority of the LAD arising from the right or anterior sinus. And the concept is that because it has to run beneath the RVOT conduit, that there's a risk or a highish risk of compression there. I think the other thing, as we've seen this morning, consider your projections. Sometimes the projection with this caudal LAO view will allow you to look down the barrel and really give you a good impression of if there is compression and where that may be. So again, coming back to the substrate, I'd like to just again emphasize that I think coronary artery assessment in the setting of percutaneous pulmonary valve implantation should be routine, definitely in the RV to PA conduit group, probably in the bioprosthetic valve group, even though some people feel that you're protected by the valve ring. 14% of the cohort in this group had coronary compression. In the native outflow, I don't know what the answer is. I think if you get caught, it's indefensible, but the likelihood is extremely small. And again, it's important just to emphasize again the high-risk groups, those with the anomalous coronary artery, those with transposition of the great arteries, and probably those with the Ross. 5.9% of patients with the Ross procedure had coronary artery compression, so slightly higher cohort or higher prevalence than those seen with the other substrates. So again, the technique, we've talked about substrate. What is the technique? Well, we've said pre-assessment is important. Biplane imaging, I think, will help. Some people may do it on a single plane lab, but I think a biplane imaging lab provides two different evaluations, and I think it can help. And then we'll go through in a little bit the balloon and coronary assessment and then the final assessment. So the camera projections I've already spoke to you. This is a 47-year-old with a bicuspid aortic valve who underwent a Ross procedure. And again, initial assessment shows that the left coronary looks okay. But when we do this down the barrel view again with the balloon inflated, we can see this clear compression here of the LAD. And I think, again, it's an important point to have a look in a number of different views or fields when we're evaluating the coronaries. So we talked about pre-assessment and the risk analysis in those with pre-existing coronary artery abnormalities. And also, I think it's important to acknowledge the RVOT. If this is a native RVOT or if there's a heavily calcified conduit, it probably is going to influence how we assess the coronaries. My advice, although this is not necessarily data-driven, is that we start with a compliant balloon. It provides a broad anatomical overview of what's going on. Start with an aortic root angiogram and assess, and then obviously if there are concerns, move to selective coronary angiography after that. So this is a person with actually it's a congenitally corrected transposition patient who'd had an anatomical repair with a heavily calcified conduit, as you can see. And this is a compliant balloon testing and a selective left coronary. How many people would proceed with this based on this? How many people would not proceed? So nobody would do anything. Well, that's great. Okay, well, I think obviously there's a little bit of a concern here because the left coronary is quite close to that narrowing. One of the things that we can do maybe to help a little bit, and I might ask you to start the video because it won't start because you'll need to, is to do a 3D rotational angiogram. And that 3D rotational angiogram suggests that the coronary may be a little bit further away, but I think in the end we decided not to proceed with this rightly or wrongly because the feeling was that it was just probably a little bit too close to where the coronary actually, to the left coronary origin. But again, this is the benefit of the coronary, the compliant balloon to start with. And I think, we need to be mindful of this is a potentially lethal complication. So taking a chance may be a chance too far. So again, although this is not a data-driven, we've talked about how we assess with pre-assessment, look with the compliant balloon. And then if you have a heavily calcified conduit, one approach may be to start with a balloon that's about 1.2 times the size of your actual narrowest portion of your conduit as it actually is at the angiogram. And then to increase with 2 millimeter balloon increments with a non-compliant balloon with serial RVOT angiograms to make sure you haven't caused any conduit disruption. And then a final balloon size close to the proposed stent diameter. Obviously, there are different approaches to this, and maybe the evolution and the availability of covered stents might give people some more confidence in relation to how they evaluate. And there's always the opportunity of moving to selective coronary angiography if you feel that root angiogram is not providing the evaluation that you need. So again, proximity, we all feel that if it looks far away, that's very reassuring. And again, this is another case from Morey's paper that I've been talking about in a 28-year-old with transposition VSD after Rastelli. Again, high-risk group, 33% of this cohort provided 33% of those with coronary artery compression. And we can see that the left coronary is quite remote here from actually where from the origin, or I should say the compression is quite remote from the origin of the left coronary. And when we look in the lateral, again, it looks as if the compression that's occurring here is actually far away from the balloon, but compression of the coronary is not necessarily related to proximity. I'm not sure why I put this slide up because it basically makes things even more confusing than it does, but I think it's important to be aware of the point that, that proximity alone is not enough reassurance and that serial testing is an important part of this evaluation. So this is a case that Ziad kindly gave to me, and is there a different way when you interpret it to see if there is compression or not? And this is a 29-year-old male who had a Ross 20 millimeter homograft and then had an aortic root replacement due to progressive AI. And you can see the coronary angiogram, you can see significant calcification of the aortic root. It's a selective left coronary angiogram, and then assessment with balloon inflation in the RVOT of a compliant balloon to see where the coronaries are in relation to the balloon. And what we'll see is that with the balloon inflate, it's probably a little bit distal there. You can see that there's good filling of the left coronary. But again, with all of that calcification, the suggestion is that conduit a little bit close to the left coronary. So we pull the balloon back a little bit more and have a look again. Again, the left fills well. One of the issues is, again, if it is towards the ostium, one of the problems you may see is that your catheter is actually beyond where you may get some of the compression. So what we decided to do is to put a coronary wire down the left coronary, the LAD, and have a look again and see with IVUS intravascular ultrasound whether or not there was any evidence of compression. Again, this is with a compliant balloon. I think you can see here that this sort of pear-shaped or kidney-shaped evaluation of the left coronary would suggest that there is some indentation here. I think it's not perfect, but it certainly maybe gave us, and then when we deflated the balloon, you could see that the left coronary was actually okay. It gave us some indication that potentially there may be a problem here, and we didn't proceed in this case. So what about 3D rotational angiography? New imaging modalities, may this help? Well, this is again a patient, this is a patient who, so I'll just go back. This is a patient who had, and again, an RV to PA conduit here. We can see an atlas balloon inflated. And again, the still image here is very reassuring to suggest that the coronaries are well away from this balloon, inflated to a diameter of which we were actually considering, or which the operators were considering putting in a valve. And again, I'm grateful to Martin Brox of the University of Michigan for sharing this with me. What about more advanced imaging techniques? Well, this is great work from Gregor Kings from Utrecht in the Netherlands. Again, looking at 3D rotational angiography. But could you play this video for me again? So what we can see here is by actually processing the data and post-processing the data, what we can do is we can evaluate the origin of that left coronary in relation to the balloon, which is the purple, and the conduit, which is the yellow, and be able to tilt and have a look at it in 3 dimensions, or as close to 3 dimensions as we can get, to determine how close that compression may actually be. And you can see again, as we pair backwards and forwards, it allows us to evaluate it, and then when we tilt it into that view, it suggests that actually the coronary is reasonably remote, and therefore I think they decided to go ahead and proceed and put a valve in a little bit lower down again in this patient to avoid any issue with the coronary artery compression. And then finally, with fusion imaging, here again we can see some 3D rotational angiography re-imaged or reformatted, and we can see again by actually pairing in or paling in and out, we can see that the coronary, which is indicated in white, and the pulmonary artery, or the pulmonary tree, in yellow, and then the balloon in purple, that there may be some suggestion of a potential for compression a little bit more distally in the pulmonary tree, but that the narrowing, which is the bit that we wanted to kind of get at, or the operators wanted to get at, is a little bit more proximally. So are there any other ways that we could evaluate that? So by fusion imaging, if you just play the video on the right-hand side of the screen, what we can see is that the coronaries are indicated in yellow, the balloon in purple, and we've gone up with, or the operators have gone up with a pre-stent to pre-stent it, and then by putting this little ring here, they've been able to identify where the best place to actually deploy the stent is to maintain a more proximal location, but still get the narrowing so that they're able to kind of avoid any potential for compression on the coronary on the left side. So again, it's balloon dilated. It's probably a CP stent, I think, that's been put in. And then again, always evaluating the position, and then post-dilating, and then eventually going up with the Melody valve to deploy the percutaneous pulmonary valve. I see some flaring just at the proximal portion of it there to help you get the valve up, because again, there's some room distally for you to be able to do that. And even though this is at 10 times the speed of normal, it's still taking a little bit of time to go. But anyway, I won't delay in it. But the Melody valve goes up, and they get a very nice result at the end of it that shows that, again, this is ensuring that the pre-stent is dilated to an adequate size, and that most of that wasting is got out of the way. So final assessment, again, we talked about this morning. I think once we've done all the good work, I think it's really important to assess at the end. Again, we talked about this LAO caudal view. Again, it shows us the circularity of the valve, also shows us the aortic root and whether there's any compression, and we can see the left coronary here filling reasonably well. And I think this has implications. This is the ICE catheter here that we sometimes use. This has implications for not only the coronaries, but the aortic root as time goes on, as we evolve with this procedure. So I'm not sure if you're still like this or if you're a little bit more like this, but either way, I suppose the conclusions I'd leave you with is a structured approach is important. Use the data we have. We do know some things. We don't know a lot, but we should use what we know, in particular in relation to the high-risk groups, and pre-assessing those to ensure that there's no pre-existing stenosis of the coronary tree. Be sequential in your approach and patient, and then a final assessment to evaluate the coronaries and the stent in relation to the aortic root, I think, is vital. Thanks for your time.